future of healthcare was going to be through systems. We could tell that the Affordable Care Act was going to be, becoming law. That law or something else was going to happen. Healthcare was becoming far too expensive. And so I'd been thinking for quite some time that we needed to change the structure of the organization to get different kinds of results. And it was actually when I had a team in Haiti with me, and we happened to be at the Papal Nuncio's compound above Port-au-Prince, and I happened to look vertically down on the city of Port-au-Prince. And it struck me how pretty it was. Now, mind you, this is, a week after a major earthquake, and there's probably 300,000 dead people down below. But from a vertical perspective, everything looked beautiful. When we drove down in the city and drove horizontally across it, obviously it was a different picture. So when I came back, we started talking about, looking at our healthcare organization through a different lens. Instead of looking at it vertically, let's slice it horizontally and then come up with a structure that could reduce that non-value-added variation. And so literally, we did a quick study and saw that we were doing, just between our 5 hospital campuses, $150 million in variation, just in our operating practices. By the way, also losing for Medicare at that time about $150 million. So it was pretty obvious to us that if we wanted to break even for Medicare, which is a goal I think of a lot of organizations now, all we had to do was take out the variation within our own healthcare system, and we could get close to that target. Everybody said, great, we'll just do that, don't change the structure. But I believe that the structure had to change. So I actually pulled all the chief operating officers out of the hospital, gave them responsibility for a horizontal structure. So one example being nursing, another example being imaging across the system, not only the 5 hospitals, but the ambulatory environment. And their charge was to identify all the practices that we were doing different. Staffing, use of supplies, quality differences, all of those different types of differences, and then working with the vertical team, take out that non-value-added variation. I intentionally came up with the term constructive tension because I expected the vertical team to protect their practice if it related to something that was safe. I mean, I didn't want to change practice and end up hurting the patients or our employees or anybody else for that matter. So they had the right and ability to push back. They didn't have to just take standardization for standardization's sake. But at the same time, the new horizontal team could challenge all the variation because there is, by definition, only one best practice. We got some terrific results right away. Well, just in the first year alone, we reduced costs by $77 million. Second year by about $60 million. This year we'll have about another $55 million. Now inflation continues along the way, so we're not exactly where we need to go. But we found all sorts of variations from staffing. We really put the patient in the middle and started to redesign everything we did. So we redesigned all of our emergency departments. So there's now a path for that 80% of the patients that really need urgent care, but maybe not emergent care. And historically, all we did is take care of that 20% and allow the 80% of patients to kind of wait. Well, now we have a path for both of them. And so our wait time is down to virtually zero. It increased the capacity of our emergency rooms. We went off ambulance diversion almost completely, and it actually ended up raising profits and lowering costs at the same time. We put together clinical care lines operating in this structure, and the doctors have been fantastic in terms of looking at their own variation. And so there's a huge reduction of therapies that, when we took a look across the horizontal, wasn't creating any value for the patients. It was just an additional cost. I remember one example was a cardiac surgeon that was using nitrous oxide at one hospital post-operatively. The same surgeon wasn't using it at another hospital. No change in outcome. He stopped the practice, and $400,000 cost savings just on that one thing alone. So literally we've seen millions of dollars of savings, and I think we're just scratching the surface because we're just now starting with the physicians, looking at physician practice variation, not just the hospital operating variation, and I think there's probably $300 million of opportunity there. I've always worked remarkably well with physicians. I've seen them from the beginning of my career as partners. But physicians very often were silo-oriented as well. They expected to have everything at their campus for their convenience, not necessarily taking a look at the cost issue. And I think the change today is that physicians now, I think, recognize that not only are they responsible for quality, but they also have to be mutually accountable for the cost of care as well. And so I think for the very first time, we're creating forums for them to understand that information that they didn't even have before. They never had the cost information before. And so when they took a look at their own variation, we compare them even blindly with other physicians. As one of my medical director in charge of our Previs Cardiovascular Institute said the other day, he says, look, he says, I'm pretty competitive. I think most physicians are competitive. And when we actually looked at the data, he says, first of all, he says, I was relieved to know I wasn't the most expensive physician. He says, but I also found out I wasn't the least expensive physician as well. And there were practices I could use and change to become more efficient. I think, a lot of the blame for physicians not working with us belong to us. We never engaged them and brought them into the process. So now the structures we have created have expanded what we call our physician co-management model, and I'm almost shocked and amazed every day at how many physicians jump in to really help us. They want a successful organization, not only from a quality standpoint, they also want a successful organization from a business standpoint as well. I think our horizontal approach works very well for us because we're a regional healthcare system. We're not so spread apart, multi-state. I think if we were, it would be a little bit more challenging, but we could then organize ourselves regionally. You don't necessarily have to have one size fits all if you're a major healthcare system. I think the model, though, of physician co-management and taking a look at non-value-added variation is clearly something that could be replicated. We've had over 65 healthcare systems either come to see us or participate in webinars and other forums over the last couple of years, and I know a number of healthcare systems have started to approach this. But it does take a cultural shift. And I remember one chief executive of an East Coast healthcare system, he says, well, this is wonderful, Chris. When did you start this? And I said, about 10 years ago, when we started changing our culture. The reality is today, I think the environment, the crisis we may be seeing in terms of cost and quality, I think will make it easier for healthcare administrators today and faster for them to create the culture shift that they need to be successful. But it's never too late to start.